So July 10th, 710, chronicdiseaseday.org is all about building awareness around the risk factors, behaviors, and providing information for people to understand what they can do to better take care of themselves or be an inspiration to others.
It does start with you, leading by example, be the change, be the inspiration.
Up until today, up until an hour ago, I never knew this existed. I'm pleased to know that something like this does exist.
We absolutely need something like Chronic Disease Day.
Great, so get on board. Get your state to participate. Use social media to get the word out and support those who need your encouragement.
I am very grateful that there is an organization such as Good Day, and I hope more organizations can join in, because the more big organizations start doing this, I think the more accessible it's going to be for people to actually know the truth about chronic disease.
710 Chronic Disease Day, it's an opportunity that we all can make a difference.
Care, commit, connect.
Hello, everyone, and thank you all for joining us to recognize Chronic Disease Day with this timely educational briefing covering COVID-19 and health disparities. I am Clorinda Wally, the president of Good Days, which is a national nonprofit charitable organization that makes life-saving and life-extending treatments affordable. I am pleased to be joined by many of my colleagues from the chronic disease community for this event. For those of you who may be unfamiliar, chronic diseases account for 7 of the top 10 deaths in America and more than 90% of our annual healthcare spending. Hundreds of thousands of Americans who suffer from unpreventable chronic and rare conditions need access to care, but the deadliest and costliest diseases are also the most preventable. We promote actionable resources to lower the rate of preventable chronic diseases so that our healthcare system can better support individuals with unpreventable conditions and invisible illnesses. Chronic Disease Day is also an opportunity for legislators to pledge their support to those of us who have chronic and rare conditions. This includes funding for medical research and public health programs, as well as advancing legislation that supports a patient's ability to access the care that they need. Our communities of support work year-round to use our collective voice to advocate for issues that impact across the chronic disease community. In this regard, I hope you will join the advocacy training webinar taking place at 2 p.m. Eastern today if you would like to know more about engaging members of Congress in support of timely legislative issues impacting our community. We have a great lineup of exceptional speakers today, so let's jump into the program. Our keynote speaker is Dr. Alicio Perez-Stable from the National Institute on Minority Health and Health Disparities, who will join us in about 40 minutes to conclude the briefing of this presentation. We'll do our best to stay on schedule and to make sure we do not keep him waiting when he's going to join us. I am now honored to present Congressman Joseph Kennedy of Massachusetts. Congressman Kennedy has served in Congress since 2013 and has been outspoken recently on the need to support our community members who have been adversely affected by COVID-19. Congressman Kennedy currently sits on the Energy and Commerce Committee and has been outspoken recently of the need to support our community members. He's been a key figure in efforts to enhance health funding and improve healthcare. He joins us through a pre-recorded statement for the community. Please welcome Congressman Joseph Kennedy.
Hi everybody, I'm Congressman Joe Kennedy. I'm so sorry that I can't be together with you today in Washington, but I'm inspired by your unwavering commitment to this cause. To say that we've learned a lot over the past few months would be a dramatic understatement. About ourselves, about each other, about the strength of our communities, about the empathy and compassion of our neighbors, but also about the chasms that exist in our society, particularly in our healthcare system. To fill those gaps in the midst of this crisis, we must expand access to healthcare for all Americans. And that's why I introduced a bill with Congresswoman Pramila Jayapal to guarantee coverage for all workers who have lost their jobs in recent months. But in the long run, we need to be bigger and bolder than we have ever been before. even if COVID-19 exposed the inequities in our system, patients with chronic diseases and their loved ones were all too familiar with them long before social distancing was a household word. That's why our fight for a stronger, kinder, more just healthcare system will continue, even after this pandemic ends. And while I will continue to draw inspiration from your community, from all those who battle chronic diseases every single day. Thank you for your fearless advocacy. I'll see you again soon.
Thank you very much, Congressman Kennedy. We're also hoping Congressman Chris Stewart of Utah could join us today. However, his schedule did not cooperate. Congressman Stewart sits on the House Appropriations Committee and has long been a champion of funding increases for medical research programs, and we thank him for that. He has also co-sponsored important bills, including the Safe Step Act and Access to Marketplace Insurance Act. We hope to see him again, maybe on Capitol Hill next year. It is now my pleasure to introduce Michelle Cuevas from the U.S. Hereditary Angioedema Association. Michelle is a passionate advocate who works tirelessly on behalf of the hereditary angioedema community. Hello, Michelle. For many years, HAA was a fatal condition, but thanks to U.S. Hereditary Angioedema Association, excuse me, I'm talking a lot, sorry. But thanks to the community advocacy and investments in medical research, there are now a variety of life-saving and life-sustaining treatment options. I know Michelle through her association's leadership of the Patient Coalition, United for Charitable Assistance. The organization fights against coverage discrimination and access policies that exploit patients with costly chronic illnesses like HAE. Michelle and the HAE community have been leading the charge to protect patient access to physician-directed therapy, preserve affordable coverage, and prevent steering into need-based or disability-based federal programs for those impacted by chronic illness. Like many chronic disease communities, the HAE community and the U.S. Hereditary Angioedema Association have been affected by COVID-19. So please join me in welcoming Michelle Cuevas.
Thank you, Clorinda, for that wonderful introduction.
Absolutely.
It is my honor. That is caused by swelling in the intestinal wall. Airway or throat swelling is dangerous and can lead to death by choking. The historical mortality rate for inadequately treated patients is 30%. The hallmark of HAE was disability and a significant risk of death. However, a few years ago, advancements in medical research led to the development of innovative therapies that took HAE from a potentially fatal condition to a manageable chronic illness. Since then, HAE patients have rejoined the workforce. They've completed school and have had the chance for a normal life, provided, of course, that they could regularly access maintenance therapy. Expensive care and medicines are unfortunately part of the chronic disease experience, and charitable assistance is essential to protecting lives and livelihood. And the U.S. HAA became a founding member of the United for Charitable Assistance Coalition because a regulatory provision written as part of the Affordable Care Act legislation allowed certain insurers to refuse payments from charities providing essential financial assistance. An important lesson that through our advocacy journey is that patients with chronic are not a good fit for the care system. HAE and other chronic and rare disease patients, they face systemic challenges related to accessing disability and safety net programs, obtaining charitable assistance, and managing out-of-pocket costs. However, we have also learned obstacles can be overcome when we band together to make our voices heard. So raising awareness of the challenges being faced and educating policymakers are the first steps toward creating positive change. This year, an increasing number of unemployed Americans and their families will turn to charitable assistance organizations to help maintain their health insurance and access to treatment after facing COVID-19 related unemployment and other financial stressors. Katy Kroehner from the Pulmonary Hypertension Association and the other co-founder of the United for Charitable Assistance Coalition will discuss how patient groups have responded to the pandemic during her remarks. I thank you all for participating in this great event, and the HAA looks forward to all of us joining together to raise awareness during this Chronic Disease Day.
Absolutely. Thank you, Michelle. And we appreciate everything you're doing on the chronic disease community. So thank you so much.
Thank you.
So next, we're going to have Katy Kroehner, who is the Senior Director of Advocacy and Treatment Access for the Pulmonary Hypertension Association. Katy is also the co-leader of the United for Charitable Assistance. Hello, Katy. She regularly assists pulmonary patients and guides them along their coverage and treatment journey. So she's uniquely aware of the challenges that they face. This personal contact and advocacy informs her efforts on Capitol Hill with policymakers. PH is a chronic and life-threatening illness that impacts the lungs, which means patients are particularly at risk during the COVID-19 pandemic. Katy has excellent insight on how the work of PHA has adapted to serve the patient community during this difficult time. Please join me in welcoming Katy Kroehner.
Thanks so much, Clarnette. I'm going to bring up some slides in a moment, but can you tell me how my sound is?
You sound perfect.
Excellent. Give me a second, everybody, to see if I can get my presentation going. We may have to go without slides. I see only an option to share Firefox or share my entire screen, not an option to share PowerPoint. Anybody has any pro tips to share with me in the chat, I will take them. Otherwise, we can just go without slides.
I wish I could provide them, but if we're not capable of putting it up, we can certainly provide it back to anyone of the audience members that wants it. If you want to just add some comments on the Facebook chat, then we can make sure everyone gets them.
That sounds great. Okay. I'm going to try one more time. No. Okay. Well, let's do it this way. So I'm going to, sorry for the delay, but as Corona said, I'm Katy Kroehner. I'm PHA Senior Director of Advocacy and Treatment Access. I'm really happy to be here today celebrating or acknowledging Chronic Disease Day 2020. I am going to spend a few minutes here introducing everybody to PHA and to the pulmonary hypertension community, and then I will focus in on how PHA has adapted both our advocacy and our patient support and engagement activities to the COVID-19 environment. So if I had slides, the next thing you would see would be a little Venn diagram showing patient organizations, medical organizations, caregiver organizations, and PHA kind of at the center of that nexus. And what I like to say here is that PHA is a little bit unique now. Certainly we were quite unique 26 years ago when we were founded. The organization was founded by a couple of pulmonary hypertension patients and the sister of one of those patients who happened to be a nurse. So right from the beginning, while the founders did really think of themselves as starting a support group, their main goal was to end their own isolation and end isolation for other folks with pulmonary hypertension. From the beginning, the organization set out to include patients, family members and loved ones, family caregivers, and medical professionals all under the same umbrella, and to provide programs and services for anybody whose life had been impacted by pulmonary hypertension. Right now, PHA facilitates about 200 volunteer-led support groups around the country. Those were in person before COVID-19. Many of them have switched to virtual programming, and they're sort of adding their in-person, now virtual meetings to our already existing phone and internet support options as well. PHA also hosts 2 medical membership networks, one for physicians and PhD level researchers, and then one for what we sometimes call allied health professionals, but your RNs, social workers, respiratory therapists, other clinicians who are heavily involved in the care of folks with pulmonary hypertension. So let's back up a little bit and talk about what is pulmonary hypertension. Pulmonary hypertension is a chronic, rare, and potentially fatal health condition that causes high blood pressure in the vessels of the lungs. It can lead to heart failure. And anybody can be impacted by pulmonary hypertension. It can impact folks of all races, genders, and ages, from young children through the elderly. The typical patient profile is a woman between the ages of 20 and 60, but that's certainly not the only patient profile. Pulmonary hypertension can be idiopathic. It can occur at any point without a known cause, just some symptoms, maybe shortness of breath, fatigue, chest pain, some of the most common symptoms coming up unexpectedly. Pulmonary hypertension can also be associated with any condition that would block or constrict the blood vessels. So it can be associated with scleroderma, sickle cell, HIV, and lupus, just to name a few. And as with so many rare and chronic health conditions, pulmonary hypertension patients face a long road, months and sometimes even years, to getting an accurate diagnosis. And that, even that long path to diagnosis, is sometimes just the beginning of the path to then getting really effective therapy. And so a lot of PHA's advocacy initiatives focus in on that topic, on getting access to therapy, whether that is, as previously mentioned, really working hard, fighting to protect access to copay and premium assistance, which is so vital to the PH community, all the way through, working to protect what we think of as care that's driven by clinical judgment. And whether that's making sure that patients have the access to the specific therapy that they've been prescribed without a lot of step therapy or benefits management protocol getting in the way of what their expert physician thinks that they need. Pulmonary hypertension, there's no cure for PH. There are therapies available, and from a rare disease perspective, we're very fortunate that those therapies are available. They are very complex, very expensive, and they do really demand the management of an expert clinician. So getting patients to the right therapy right away after they've already lost time getting a diagnosis is really critical. On May 5th, in honor of World PH Day, PHA would have hosted an in-person legislative luncheon, which typically brings about 100 legislative staff people together with members of the PH community to learn about how Congress can use legislative opportunities to improve life for folks with pulmonary hypertension. About a month later this year, on June 12th, PHA would have hosted our international conference and scientific sessions. This is an every other year event that again brings together patients, family members and loved ones, and medical professionals for a variety of educational opportunities. And it is highly anticipated. I have friends within the community who I know start saving money, 2 years in advance. As soon as one conference is over, they start saving for their trip to the next conference to make sure that they will be able to be there 2 years later. Brings together about 1,500 people. Again, just a highly anticipated event. And so when PHA's Board of Trustees, made the right call in March to say that PHA was canceling all of our in-person events for the second quarter, the question really became, what do we do next? And after a lot of brainstorming and teamwork within the organization, the answer became a series that we're calling our PHA Connect Series. PHA Connect is a combination of Facebook Live, webinars, which we call virtual town halls, but they're webinars, and some virtual support and sort of social engagement opportunities. And that program has really gone a long way toward helping to fill some of the gaps in programming that folks were hoping to receive by attending conference this summer. The program kicked off with a Facebook Live Q&A with an expert medical professional in pulmonary hypertension, answering questions about COVID-19. And as of June 30th, that session had gotten about 7,000 views in English and about 2,000 views in Spanish. Since then, our most attended, live in the moment event was one on managing stress and anxiety. And the one that had received the most views besides the Facebook Q&A by June 30th was one on telemedicine and what to expect from a telemedicine appointment. So we're really excited about the PHA Connect series and the way that PHA has been able to continue our community engagement and support through our online venues. In conjunction with PHA Connect, we also ran our Together Through Advocacy campaign. This was shifting the advocacy activities that would have happened both in the spring and at conference to a virtual format. So again, we were looking for something that was definitely going to put members of the PH community in touch with their members of Congress. But other things that happen during those events are that we have an opportunity to identify new advocates and really bring people into the fold that we might not have acted with in the past. And also just to really remind folks that during this difficult time with the pandemic that can feel so overwhelming and sometimes leave people feeling a little isolated and even a little hopeless, that they really do have a voice. They have a way of fighting back, and that all of us working together, we can break through a little of that isolation and make our voices heard. And so the Together Through Advocacy campaign aimed to do those three things by allowing folks to email, call, or do a planned, a sort of televisit, a planned phone call with their members of Congress. Through the campaign, folks did end up mostly focusing on email, and to date, they've sent a little over 500 emails to members of Congress. We have been able to engage some new advocates that way. So, it's never the same doing an online event versus doing an in-person opportunity. But I think that given the circumstances, I'm really excited that we were able to both reach members of Congress who probably would not have attended our online event and hopefully also reach some advocates who might not have participated in something different. And hopefully we have some new advocate involvement from this point forward. So I'm just going to stop there, and I'm happy to answer any questions or take discussion at the appropriate point in the program. Thanks so much.
Thank you so much, Katie. We certainly appreciate all you're doing on behalf of the PH community. So thank you again.
Thanks.
Next up, we have an incredible community advocate with us today in Chris Draft of the Chris Draft Family Foundation. Chris has dedicated himself to working on lung cancer issues on behalf of his late wife, Keisha. Hello there.
How you doing?
Many of you know Chris for his success on the field when he was playing in the NFL as a linebacker with teams including the Chicago Bears, the San Francisco 49ers, Atlanta Falcons, Carolina Panthers, the St. Louis Rams, and Buffalo Bills. Everyone should also know Chris for his ongoing efforts to raise awareness and improve health outcomes for those battling lung cancer. So thank you again, Chris. It's all yours.
Thank you for the introduction.
Absolutely.
So it's my pleasure to be here. Thank you for having me on. Thank you for putting together this Chronic Disease Day. I have to say thank you to Patient Services Incorporated for reaching out to me and asking me to join today. So want to just throw out those shout outs before I get going and say that I'm excited that I can even join in on this meeting, or on this briefing and talking about lung cancer as it relates to it being a chronic disease. So much innovation has happened over the last 10 years. My wife, Keisha, was diagnosed with lung cancer in December of 2010. And she was in amazing shape. I mean, she was strong. She, just amazing shape. 37 years old, had never smoked, and is diagnosed with lung cancer. And we found out on that day that anyone can get it. Anyone can get this disease, and it doesn't matter. And unfortunately, the symptoms are not always very overt. So they can be very acute. And so, unfortunately, she was diagnosed stage 4. Lung cancer in January of 2010, and then passed December 27, 2011. And, so unfortunately, you really get a chance to just see this disease and really understand how very quickly that it can affect somebody and take them away. So I was blessed to be able to walk with my wife. I was blessed to be able to be there with my wife. But in doing that, I also have a chance to really appreciate the work that is happening now and really be able to appreciate the improvements that are happening in the lung cancer community that are making lung cancer more of a chronic disease. And so I say that because it's critically important in recognizing that there is a cost to survivorship. And I think that's what we're talking about here, which is so important, is that we want people to survive. We want people to live. But in doing that, there can be a huge cost. And that huge cost is not just incurred by the individual, but is also incurred by their family and their communities around them. So much of the work that we're doing in lung cancer, as we're changing the face of lung cancer through my foundation, the Chris Draft Family Foundation, is realizing the importance of prevention. And so too often within lung cancer, they're worried about the fact that for too long, lung cancer has only been seen through prevention. And it's unfortunate only by the fact that it's only been seen that way. We can still do better in terms of prevention. But the key in terms of early detection, we have to be able to fight for early detection, because that's going to allow us to find it early and potentially have surgery, which, again, by having surgery, that's the best chance to not have to be so involved with the medical community other than having scans moving forward. Next best thing is treatment. We see right now there's been an explosion in the amount of treatments that have happened, but unfortunately those treatments are very expensive. And then you look at just the importance of research, and that's where we have to have an investment. But like I said, that investment that is changing lives, that is making things more of a chronic disease, also creates a cost. And so I'm excited about all the changes that are happening. I'm excited about our fact of changing the face of lung cancer and that we are moving things forward. But it's important, again, to recognize there is a cost to survivorship. Survivorship is amazing. That's what we want. We want people to be able to live. We want them to live amazing lives. But we also have to recognize it's not just as easy as just getting treatment and just staying alive. Thank you for having me. I'm glad I'm able to join you. Thank you.
Thank you so much, and thank you for sharing your story and committing your life to ensure that proper education is known throughout, because you're absolutely right. Prevention across many different types of cancer could be key in long-term survival and even pre-detection, so you don't get to stage 4. So thank you again. We appreciate you.
Thank you.
Up next, we're thankful to have Hanna Olson. Hanna is the founder of Chronically Capable, and she's here with us to share her story. Hanna is hi there. Hanna is a Lyme disease survivor, a national Lyme ambassador, and global ambassador for Invisi Youth Charity. She founded Chronically Capable, an employment platform that connects chronically ill professionals to companies looking to hire an inclusive digital workforce. Her story and platform are especially relevant to today's discussion. Welcome, Hanna.
Thanks so much for having me. So as mentioned, my name is Hanna Olson, and I'm the founder and CEO of Chronically Capable, an employment platform for chronically ill and disabled professionals. I got into this work after Lyme disease nearly derailed my early career in Washington, D.C. Demoralized, I began to worry there was no place for people like me in the workplace. There wasn't time to completely suffer from illness or disability. So I decided to change that. Last year, I founded Chronically Capable, the first platform specifically designed to connect chronically ill and disabled professionals to flexible and remote work opportunities. We are living in amazing times. Many people with illness and disabilities came into the COVID-19 crisis already having faced significant exclusion in the workplace. And for millions of chronically ill people around the world, coronavirus has had one totally unexpected side effect. It has increased accessibility. The new rules for working have opened up a world of employment opportunities for those whose career choices have been limited by their health. The millions of people who had previously been left out of the workplace can now gain access to traditional employment and apply for jobs on a more level playing field. This may be one of the most significant steps towards workplace equality that we've seen to date. But there's still so much work to be done. Employers cannot fall back on those same tired excuses. We cannot continue to refuse flexible working arrangements for the chronically ill. We are in a time where workplace change is crucial for the 157 million Americans suffering from chronic illness. Thank you so much for being here today to show your support for Chronic Disease Day and for the chronically ill and disabled community. Myself and my community will not stop fighting to make the workplace more inclusive for all. I hope you'll join us in the fight. Thank you so much and have a great rest of your event.
Thank you so much. And I certainly think that businesses across the country are now learning, unfortunately due to COVID, that working from home can be just as productive as working in an office. So thank you for everything that you're doing.
Absolutely. Thanks for having me.
Absolutely. So now we are honored to have the director of the National Institute on Minority Health and Health Disparities, Dr. Alicio Perez-Stable, with us as our keynote speaker this year. Director Perez-Stable will discuss recent advancements and emerging opportunities related to COVID-19 as a health disparity. The public health crisis in our country is unprecedented. It has created a new set of challenges for those of us with underlying health conditions. Communities of color have been hit especially hard by COVID because of disparities that lead to higher risks of underlying conditions, including diabetes, heart disease, and lung disease. NMHD seeks to resolve the disparities in advanced research, training, public education, and information dissemination on behalf of minority communities and the public at large. Dr. Perez-Stable practiced general internal medicine for 37 years at the University of California, San Francisco, USCF, before moving to NIH in September 2015. He was chief of the Division of General Internal Medicine for 17 years. His research interests include improving the health of racial and ethnic minorities and underserved populations. He was elected to the National Academy of Medicine in 2001. Please join me in welcoming Dr. Perez-Stable.
Thank you very much.
Thank you for being with us.
Thank you for that kind introduction. And it's really my pleasure to be able to speak to this audience. Good afternoon, everyone, or good morning if you're further west. I usually speak from slides, and I'm not going to do that this afternoon. I want to just talk to you about some general principles related to social determinants of health and how this has magnified under the current COVID-19 pandemic, and how this actually is especially synergistically magnified with people with chronic disease, as pointed out. Our institute at is part of NIH, which is the main scientific organization for research in the world, and certainly in the United States. Our institute is 10 years old this year. We were founded on the principle of addressing racial and ethnic minority health, less privileged socioeconomic status, or the health of all poor people, independent of color, as well as underserved rural residents. In 2016, we added sexual gender minorities as a population of focus for our institute. And we define a disparity as a worse outcome on these populations when compared to a reference population, be they urban or whites, or people who are better off socioeconomically. We also embrace the unifying concept that all of the disparity populations are affected by discrimination, and this leads to a social disadvantage, which contributes to worse health. And this, I think, is an important unifying concept in all these populations. Everyone's familiar with the racial ethnic categories in the US. They have limitations, but they do provide us with a guide. I part from the principle that race ethnicity is a self-identified construct. It explains a lot of things that are not strictly explained by behavior or biology. And we use that as a central emphasis of research in all the research we do on healthcare outcomes, and encourage that this be considered as such, not as a categorization only, but really as a tool to be able to understand what happens. If you look at life expectancy in the US, you can see big differences between white Americans and Black Americans, as well as Latino or Hispanic Americans that are not fully explained by socioeconomic status or behavior or other conditions. So I think this is the utility of having this as a central tenet. African Americans have a lower life expectancy than whites for both men and women. Women actually live longer than men, and that's very consistent across much of the globe. And among Latinos, we see that they actually have a mortality advantage, a life expectancy advantage that many think is due to the immigrant paradox that may actually go away with time as a higher number of Latinos are born in the US. Now, on the socioeconomic side, this is a critical determinant of health, as we can look at if one lives at the poverty level of about $25,000 a year for a family of four in a household, one is 3 times as likely to die from any cause than if one had an income, a household income of $115,000 a year. Now, $115,000 a year is well off, but it's definitely not wealthy. And this gradient of mortality that one sees, of predicting mortality, is as strong as one would see from one who smokes cigarettes or have elevated systolic blood pressure or other conditions that we know predict life expectancy. And yet we infrequently think about this when we take care of patients or when we're seeing someone with chronic disease or acute problems as a factor that determines outcomes. NIMHD scientific staff have developed what we call a research framework that tries to take into account all of these factors, not trying to explain things by saying causal pathways are defined this way, but think about both individual and interpersonal, as well as community and societal or structural factors or levels of influence, how they interact with the biology of the individual, the behavior of the individual, the physical or built environment, which has really been eye-opening to see the research of how important this is, the social cultural environment, or how we interact with other people, and of course the healthcare system, in particular for persons with chronic disease who have lots of interactions with the healthcare system with the goal of controlling their chronic condition. And these all interact in different ways that require both research as well as ways to intervene to improve individual outcomes. Now, what's happened with the COVID-19 pandemic? Early on, I certainly did not think or consider that this would be something that would disproportionately affect minority populations. After all, we don't see this with flu epidemics necessarily at all. But by the middle of March, late March of this year, was clear from reports coming out of Connecticut, New York, Chicago, Milwaukee, and Georgia, and then New Orleans, that African Americans who contracted COVID were more likely to be hospitalized with severe illness and end up on a ventilator and increased mortality. This was initially explained by the observation that the rate of chronic conditions, such as diabetes and cardiovascular conditions, were higher among African Americans. And this was the explanation given. This has been consistently found now that we have a lot more data, although we still have incomplete information on race and ethnicity. It's clear that diabetes and all cardiovascular conditions, including high blood pressure, are associated with a higher risk of death from COVID-19. So the severity of the disease is worse. Chronic lung disease as well, although not as robust a predictor of mortality. And then a lot of other conditions that impact the immune system and our body's ability to manage this infection. There's a second component there which has become clearer in the last couple of months, and that is the risk of contracting the infection. As we went into societal shelter-in-place mode for much of the country, there were a number of persons who continued to work because they had to. They were part of essential businesses. Our grocery store workers, pharmacy workers, transportation, security, and other services. These professions are disproportionately represented by minority communities, particularly African Americans and Latinos. And therefore, the risk of being in a public-facing position and the risk of being infected goes up in those populations. There's another component, which is if you don't work, you don't have funds to pay rent or food because they don't have sick leave, they don't have sort of the ability to be able to stay home and continue to be paid, or telework and continue to be paid. And therefore, there was an incentive to continue working independent of whether you were sick or not. So you can imagine that we're setting up for transmission to occur amongst those individuals into the community at large, which continue to, of course, shop and need to buy medicines and food, etc. In addition to that, there is the challenge that many of our poor communities live in urban centers in housing that is more crowded than middle-class individuals. So in the same apartment space that one family may live, there could be three. There would be three generations because the grandparents, parents, and children are all there. There isn't a way to self-isolate in those apartments, in those housing spaces. There may only be one bathroom. It is a challenge for these families to remain and adhere to the recommendations about mitigation of transmission. So I think it is imperative to take these two lenses into consideration. But are there race, ethnicity groups that have higher rates of comorbidity, therefore more likely to have severe infection and death? Are there generally poor people and minority communities live in more crowded situations, higher risk of transmitting the infection among themselves, in addition to the fact that they're disproportionately represented in the occupations that are public facing and therefore more likely to be infected themselves or to transmit the infection. Now, the National Institutes of Health, through the leadership of Dr. Francis Collins, has received supplemental appropriations from Congress in the past 2 months. Dr. Collins, the main goal of this appropriation was to address testing for COVID-19. This came in late April. Dr. Collins decided some of the funds were definitely to go to develop better point of care tests. So one could get tested in remote areas, in areas that are far away from a big laboratory. That is in the process of being developed, getting innovation from our best technology and engineering minds in the country. There is investment in perfecting what is the serological test, or the tests that the antibodies go up after you've been infected. Therefore, are you immune or not? We don't know. It's still not clear, although it appears that over 90% of people who recover from COVID-19 do develop the antibody type we call IgG, which should be at least provide some immunity, if not partial or complete immunity for some period of time. And this is important to know as we navigate this pandemic. And the remainder of the funds were allocated by Dr. Collins in different ways. A significant amount was allocated to what we call rapid advancement of diagnosis for underserved populations. This is a first for NIH, a significant investment to address the problem, in this case of COVID-19, in underserved communities, addressing underserved and vulnerable. So this is targeting all individuals who would be classified as underserved, minorities, poor people, people who have not had access to healthcare, as well as those who are more vulnerable to getting COVID-19 severe infection. And it's an opportunity to create a consortium of sites that we would initially do testing in, collect information on in terms of research, and then be able to potentially use this information either for addressing contact tracing and control of the pandemic through those methods, or hopefully in the next year be able to use this framework to address deployment of what we hope would be an effective vaccine. Since the characteristics of this pandemic are changing on a week-to-week basis, we need to continue to be open to possibilities. Hopefully in the future, in the not too distant future, we'll have tests that are at the site, maybe home base, using saliva. This is up to the developers to come up with this. Right now, it is still a nasal swab that goes to a lab for the gold standard detection of the DNA of the virus. Our efforts are going to be focused on large networks as well as smaller ones. We do hope to cover the country as much as possible with about 50 to 60 research sites that would be funded. We want to include all race ethnic groups, from tribal nations to general population groups. We want to overrepresent the most vulnerable groups. So residents of chronic care facilities or nursing homes, people with chronic lung disease or chronic cardiovascular conditions, and people with diabetes. And so this is our goal. It is ambitious, but and innovative and novel for NIH to embark on this path. But this is the kind of response that this crisis really demands of us at the National Institutes of Health. We will do research as well, a smaller type of research, and we will try and coordinate everything through a coordinating center that will be able to maintain the community engagement, the data science side, as well as the technological side that needs to be sustained here. So with that, I will close, and please do not hesitate to contact us at NIH. We have lots of information, and we're always welcome input from our constituents, which are really the people from whom we're trying to advance health.
Thank you so much, Doctor. And again, thank you for all you're doing on behalf of the minority communities. And again, if anyone has any questions, feel free to send them out to us. And as we can, we'll disseminate them and provide answers from our many different speakers today. So thank you again. And thanks to all of the speakers that we've had today. Thank everyone for joining us on Chronic Disease Day 2020. We also hope you'll tune in to this afternoon at 2 p.m. Eastern for our advocacy training webinar. It's a 30-minute informational event regarding how you can advocate to support chronic and rare disease funding priorities at the NIH and CDC, as well as timely legislative requests impacting those with chronic illness. We hope you'll continue to share your story and help us raise awareness in support of the chronic and rare disease community. Thank you all. I do want to put a shout out to Wellacopia, who was Chronic Disease Day's premier sponsor this year. So thank you so much for your support. Thank you all again. Stay safe and take care of yourselves.